If we have permission from Bhaskar sir, can we go ahead with the panel, sir?
Yes, please.
Okay, thank you so much, sir. And now I am delighted to invite and introduce Dr. Sujata Dalvi ma'am. We better know her as Beauty with Brains. She is consultant obstetrician and gynecologist from Mumbai, President Mumbai Menopause Society, Joint Associate Editor of Jogi, Secretary Amox. So many credentials to her.
That's fine.
So, ma'am, the platform is all yours.
Yeah, if you could invite all the panelists, I would appreciate that. And then
Okay.
we'll go ahead, if you don't mind.
Surely, ma'am. Dr. Shoma?
Yes.
Yeah.
Thank you, ma'am. We have among us our esteemed panelists who are here to enlighten us with their knowledge and experience. We are happy to have Dr. Bishwajyoti Guho, our Honorary Secretary of Bengal Obs-Gynae Society 2022-23. He is the member Perinatology Committee FOXY, Vice President ISOPOP Kolkata Chapter, and the Clinical Examiner of MSCOG Part 3. Next slide. We are fortunate to have Dr. Dipti Goswami ma'am as our esteemed panelist. Madam is a Director, Professor and Unit Head in charge Gynae Endocrinology Clinic, Faculty Reproductive Medicine and IVF, Maulana Azad Medical College. Madam is the past Secretary, Association of Obs-Gynae Society of Delhi 2022 and 23. She has numerous publications in many prominent journals. Welcome, ma'am. Next slide. We are enriched by the presence of Dr. Krishna Kumari ma'am. Dr. Krishna Kumari ma'am is the Professor of Apollo IMSR, Hyderabad. Senior Consultant Medicover, Women and Child Hospital, Hyderabad. Madam is the Vice President, Telangana Congress of Obs-Gynae Society, 2018-21. Governing Council Member, ICOG, 2018-2021. She was the President of Obs-Gynae Society of Hyderabad, 2017 and 19. Faculty at local national FIGO conference and many postgraduate programs. Welcome, ma'am. We are happy to have among us Dr. Nilakshi Kokan Kumar, Consultant Downtown Hospital, Dr. Kesidas Nursing Home, Guwahati. She is the President of Guwahati Obs-Gynae Society, former Secretary, IMS Guwahati Chapter. She works enthusiastically on cancer awareness in women of Northeast region. Welcome, ma'am. We are happy to have among us Dr. Pradeep Ganiga, sir, Head of the Department, AJ Institute of Medical Science, Mangalore. Welcome, sir. We are enriched by the presence of Dr. Rajendra Nagarkatti, sir, Clinical Secretary of Mumbai Obs-Gynae Society, immediate past Chairperson, FOXY Midlife Management Committee, immediate past Chairperson, AMOGS Midlife Management Committee, past President and Advisory Board Member, Association of Fellow Gynecologists, Mumbai. He is the IVF Consultant and Board Member of Preferred IVF Center, Kandivali, Mumbai. So, Madam Sujata Dalvi, ma'am, the stage is all yours.
Yeah. So thank you so much for introducing all my esteemed panelists. And before I start with my panel discussion at an outset, I would like to thank the convener of today's program, Dr. Bhaskar Pal, for giving me an opportunity to participate in this wisdom webinar series, the first series on this panel discussion on bleeding in the first trimester. I would also like to acknowledge the national coordinators, that is Dr. Basab Mukherjee and Dr. Sibanti Goswami, as co-coordinators for this webinar. And I would like to see even national coordinator. I can see one, that is Dr. Shaila Jamaat. I would like to thank her and of course you, Soma, for introducing all my panelists. And before we start, I would like to wish all the best wishes to Dr. Bhaskar Pal for his future endeavor in FOXY. Thank you so much. Can I share the screen? Yes. Okay, so the thing starts with a case-based studies, that is bleeding in the first trimester of pregnancy. And these are all my panelists, who are esteemed panelists from different parts of India, right from Bengal to Mangalore to Delhi to Mumbai to Guwahati and to Hyderabad. We'll start off with the first case. This patient is a 24-year-old patient, married since last 2 years. She is a primey with 6 weeks of amenorrhea. Her urine test has come positive. but she gives history of bleeding per vaginum last 2 to 3 hours. There's no history of pain in the abdomen, no history of passing blood clots, no history of any heavy physical exertion, or no history of any sexual contact just prior to this. This was a spontaneous conception, and she has a regular menstrual cycle. I would like to start off with, maybe we'll start off with Dr. Pradeep. Would you do clinical examination, and how would you go about this, treating this patient? She has come to you in RR and she gives history of bleeding PV 2 to 3 hours. And how will you go about? Dr. Pradeep, please. Yeah, Dr. Pradeep. Any difficulty in logging, or should I go with the next one?
Dr. Pradeep, we can't hear you. Dr. Pradeep, we can't hear you.
Pradeep
Or
sir,
should I-
unmute yourself.
Okay, I think we'll go ahead with the next. Dr. Bishwajyoti, could you just start off with this? Then maybe Dr. Pradeep can just
Good
figure
evening.
out what. Yeah. Dr.
Good evening,
Bishwajyoti.
Dr. Dalvi. Thank you. Thank you very much. At the very outset, I would like to thank Dr. Bhaskar Pal and the whole Wisdom team for having me today in this, very important and fruitful discussion that we are going to have on first trimester bleeding. Now, clinical examination, this is a 6 weeks lady who has come with history of vaginal bleeding with possible pain in the lower abdomen. Now, first of all, I'm going to do a clinical examination, whether our vitals are stable or not. Internal or vaginal per vaginal examination, I'll do a speculum examination perhaps,
Correct,
just to see
yes.
whether the os is open or not, and whether we can see any products hanging from the os. Now, sometimes what happens in this kind of ladies is come in a stage of almost hemodynamically unstable, in a shock, but not that amount of bleeding. But when you put a speculum inside the vagina, you see the cervix dilated and the products hanging out. And once you remove the products, everything becomes okay. So this is something that we need to just exclude.
1 second. Is it always that you see the products, or could you see look out for some lesion on the cervix also?
Yeah,
at times if at all? Yes.
that is of course, when you are looking at the cervix, we also look at if there are any erosions on the cervix or any sort of polyps which might be bleeding from the cervix.
Correct.
And investigations is routine investigations. We are going to do a hemoglobin, we are going to do a CBC, we are going to do a beta HCG level for her, and of course the routine blood tests such as blood group and typing. At this stage, I would not be doing any sort of coagulation studies, but later on, maybe
The routine investigations, what is needed, including beta HCG, you would do it. I would like to ask Dr. Dipti, what about an obstetric sonography? And if so, how will you do it? Dr. Dipti, please.
Yes, obstetric sonography for sure helps us decide about that pregnancy, especially if the os is closed, and particularly if it is a viable pregnancy or it is a non-viable pregnancy based upon presence or absence of the fetal heart. Even though my predecessor expert has said that he will do a per speculum examination and not a per vaginum, but as far as we follow in our medical college and at several others, the traditional teaching, where especially when ultrasound is not available at all centers, is to do a per vaginum examination. Because so many times, yes, we still do it.
Yeah, we still do it, but we are a little gentle and we explain to the patient that this will be a gentle, but this we want to know whether the os is open or no,
Yes.
So then
Yes.
they get convinced for vaginal examination.
Exactly. My teaching is always to have in your head what are the possibilities. Number one, on basis of history. Number two, on basis of clinical examination, try to figure out whether it could be threatened or a missed or an inevitable. What type of abortion? She is 6 weeks abortion. She is 6 weeks
That's right.
amenorrhea. We don't know what she could be. She could be anything, right from ectopic to missed to threatened to an incomplete to anything. So a clinical examination, according to me, I will do.
One thing I
An
wanted to ask
ultrasound.
you, yeah, obstetric ultrasound, Would you prefer a transvaginal? You get a better picture as compared to
I will do a,
transabdominal.
yes, I will do a
Yes, but
transvaginal.
still,
I will do a transvaginal.
you would do a transvaginal.
Yes,
Even if she is bleeding, it's always better to do a transvaginal where you get a
yes,
clearer picture of what
yes,
exactly
yes.
is there within
I
the
mean,
uterus.
suppose patient is having bleeding, suppose you have to have full bladder, how will you get a full bladder immediately? Or you make her wait, let her bleed. There are so many logistics. And anyway, the image you get with transvaginal cannot be compared with what you get in
That's right. That's
transabdominal.
right. So in spite of patient bleeding, it's always better to do a transvaginal. You get a better idea of it. I would like to ask Dr. Krishna Kumari, when this patient comes to you, would you admit the patient and what all treatment would you give after you admit the patient?
Good evening, Dr. Dalvi.
Good
And at the
evening.
outset, I would like to congratulate and thank Bhaskar and his team for inviting me on this very first webinar and wish him all the best. Thank you. Coming back to our question regarding admission of this patient, first of all, I would like to confirm if it is whether she is hemodynamically stable or not. If she is hemodynamically stable, and if it is showing, the scan is showing a viable intrauterine pregnancy, then we have the benefit of we counsel the patient regarding the advantages of being hospitalized versus home care. So it again depends. If the patient is not hemodynamically stable, or if the fetal heart is if the os is open, and if it is suspecting ectopic or anything beyond non-viable intrauterine pregnancy, yes, definitely, I think she needs admission.
Yeah, but even if she is hemodynamically stable, any bleeding patients with a pregnancy which is there, generally they are not happy if we send them home. They would always like to get
Yeah, yeah.
admitted for
We
observation.
counsel them
Yes,
advantages and disadvantages. There's
correct.
always a gap between the public and private sector, I would say.
That's right.
So I think in the public sector, it is very easy to admit them, whereas in a private sector, we always have to look at many other factors when we. So it's, I think, if everything is normal, maybe the patient's
Fine.
choice
Yeah,
may be
yeah.
there.
One more thing you said, heartbeats or no, but at 6 weeks, sometimes you may not get.
May
At
not.
7 weeks, yes. At 8, 7+, you will get it. So if 6 weeks, if you don't get it,
Yeah,
still,
then
how would you
we,
counsel the patient? Yes.
yes, if it is 6 weeks, like Dr. Deepti said, vaginal, a transvaginal scan may pick up a heartbeat. If the heartbeat can be picked up, we are all more reassured
Happy. But
about
in case
yeah.
heartbeat is not
In
picked
case
up,
it is not
what
picked
else
up,
will you see so that you can say, okay, this pregnancy is good, and maybe you can tell her we'll repeat a sonography after a week and you would get a heartbeat.
yeah, if the heartbeat is not there, maybe still I would go with the beta HCG. And in the ultrasound, I would be looking at other things like the internal loss, the presence of the corpus luteum, if there is any subchorionic bleed. So many other factors.
But what
also
about the
do influence.
gestational sac and the yolk sac?
Yeah,
You need
you
to
have to
get
see
a
the
regular
yeah, you have to see
outline.
the,
Yes.
Yeah, yeah,
So,
the
If you get a
regularity of
fetal
the
pole
gestation.
which is there,
Correct.
so
so
these
we
are the
need to
signs.
look
These are the
we,
things which you get it on a sonography.
What,
Where
what,
yeah, you have to
Yeah,
look at the
confirm it is an
periodicity of the
intrauterine pregnancy. It
yes,
first of all, if
I'm
we
just sticking to intrauterine. I'm not talking about extrauterine. We'll just stick to intrauterine.
so so if the other things that we should be looking in the ultrasound, as Dr. Nagarkati rightly pointed out, is to see whether she is having a good choriodecidual reaction,
That's right.
if there
That's
is any
right.
subchorionic hemorrhage or not, and also whether the gestational sac is regular or irregular.
Correct.
Now, if it's
Yes.
an
and also the
irregular
yolk
gestation,
sac.
yolk sac too.
Yeah.
So if
Raju,
the
I'm coming to you after this.
so if the
Okay.
yolk sac, if the gestational sac is irregular and she has got a big subchorionic hemorrhage, we know that
Correct.
the prognosis might
Yes,
not be
yes,
that
yes. I agree with you, doctor. Now to Raju. Raju, this patient has come to you. She's 6 weeks, good intrauterine pregnancy. Everything is okay. Now, how will you go about managing this patient? You have given folic acid, multivitamin, everything. What about role of progesterone? Over to Dr. Raju.
Yeah, thank you. Yeah, first of
She's
all,
bleeding, Raju. So she
yeah,
needs
So
some prompt
first,
treatment. Yes.
ideally, we should also check and look for any bleeding disorder that she may be having. So probably investigation, CBC,
with a
That doctor already said, Raju, that is all
Okay.
done. There's no bleeding
Yeah. So
resolved. Yes.
progesterone is the drug of choice at this point of time, as this is a case of threatened abortion. Now, again, in progesterone, there can be, you can either use oral progesterone, or you can go for the injectable, or of course there is the vaginal progesterone. Now, when there is bleeding, the patients would not.
Yeah, when there is bleeding, Raju, they would be happy with giving them what? Injectable,
yes. So
they
then,
would prefer
yes.
that. Yes.
Yeah, in that case, yes, the injectable natural micronized progesterone, as you have rightly pointed out here, milligrams is what I generally prefer, because sometimes the 200 milligrams can be very painful. So 100 milligrams of natural micronized progesterone intramuscularly stat, and then daily it can be given till the bleeding stops, and then you can probably go on to a maintenance dose. Along with that, you can also give our oral progesterone in the form of dydrogesterone. You have a whole
Raju will come to oral little later. I wanted you to speak on what about oil-based 17-alpha hydroxyprogesterone caproate. We've been using it for years and years, but last few months we have stopped using it. So any reason for why we have stopped, apart from because it's oil-based, it can lead to abscess or something, anything else that?
No. I think basically 17-alpha hydroxyprogesterone caproate is not for the use in first trimester. It is not the drug of choice for a threatened abortion. If at all there is a role, it is maybe for prevention of preterm labor. So I definitely not use it in the first trimester.
Correct. And what about aqueous injection? Have you used it?
Yes. Now, for the natural micronized progesterone,
that's right. Aqueous only. Aqueous.
Yeah, there is option of oil based as well as aqueous. Now, aqueous, it started with 25 milligrams per ml, and now today we also have the 50 milligram injections. It is said that the absorption is better in the aqueous form, and therefore that dose of 25 or 50 is equivalent to your 100 milligrams of the oil-based preparation.
That's right.
The only thing is there are no international papers or studies on this. What there is all the Indian studies, and which have shown that they are supposed to be equally effective.
Yeah.
I don't use it where I have to bank upon it. If it's a very precious pregnancy, I would still prefer to go for the standard oil-based natural micronized.
Fine. So oil-based has got little longer action. Aqueous is for immediate action. So if you want immediate action, you can give aqueous. Later on, you can follow it up with oil-based. I would again like to go back to Dr. Pradeep. What about oral progesterone? You've given her injection, she is fine.
Yes, ma'am.
But you want to maintain it. So what about oral progesterone? Which type of oral progesterone would you prefer? We have 2 molecules which are available in the market, doctor.
Yeah, it's one thing I think about. Can you hear me, ma'am? Can you hear me now?
Yes.
Yes, please.
Yeah.
We can hear you, doctor.
First of all, thanks to the Wisdom webinar team for giving me the opportunity. First of all, I want to tell about a natural progesterone. We all understood that if you give by oral supplementation, the dose required is almost 50% more than the whatever the vaginal route. I think in the practically, as of now, I don't prefer to give natural progesterone in the oral route.
Oral, fine. We are coming to vaginal later on. So which oral preparation would you prefer then?
Yeah, presently I think is a dydrogest we all prefer.
Correct.
It's a trusted molecule. It's a very good compliance for the patient side. It's a proved effect. I start preferably TAD or BD. I will continue up to 20 weeks. That's my usual plan. Whenever we come with the
dydrogesterone, everybody has switched so far as oral route is concerned. And now there are some companies which are planning to come out with sustained release. So you might not have to give it 2 or 3 times, maybe once in a day, and that should be good enough.
They've already come out.
They've already come out. Today, some company came and told me, madam, we're coming out with sustained release. Anyway, you said vaginal progesterone. Which are the patients you would prefer a vaginal progesterone? This patient is bleeding. So when you try and tell her to use vaginal progesterone, she may not be very happy. So which are the patients you would prefer to give vaginal progesterone, doctor? Dr. Pradeep.
Yes, ma'am. However, I think in the risk scoring, I mean, whenever we take the history, we will come to know that some women will have some risk factor for abortion. It may be spontaneous abortion. Such women in the practically we give vaginal progesterone. And whoever conceived by ART, we give natural and pregnant progesterone. And one more thing is someone complaining of spotting or someone having subchorionic hematoma. Can you hear me?
Dr. Nilakshi, there is some disturbance from behind. Yes, Dr. Pradeep, you go ahead.
Yeah, whoever comes is spotting or some conceived by ART or some risk factor for abortion. And we prefer to give vaginal progesterone for certain time,
Correct.
thinking
So
that
these
it
are
will
the
prevent.
patients who are quite patient compliant so far as vaginal route of progesterone is concerned. Whereas those who have conceived spontaneous and they don't have to undergo, these are the patients that are not very keen on using a vaginal progesterone. That's what I've seen in my practice. Anybody has used a vaginal gel? Dr. Pradeep, would you like to say something on vaginal gel?
No,
If at all somebody
no,
has
ma'am.
used it?
I don't have any experience,
Okay.
but I have
Anyone
seen
else, Dr.
theoretically it can
Nilakshi?
be recommended.
Nilakshi, by any chance, anybody has used vaginal
Yeah, we
gel?
use it. We use regularly in our IVF patients. We use vaginal gel twice a day because it is a very easy way, a comfortable way, and in the gel form, it spreads evenly all across, and the absorption is very good. So in patients where it becomes a little more expensive as compared to the capsule,
Yeah.
but it
But
is the best.
Raju, do you teach them how to use it? Because if
Yes,
they
yes,
don't
yes.
know how to use it, there are chances that, I've seen one or two patients that come with some bleeding because they didn't know how to use it,
No, it's we just show them. We open the first packet. We show them the gel. We show them how the cap has to be removed and then it has to be inserted, and they just have to press the piston. And it's yeah. So in fact, the first application we do it in the hospital. So
Okay.
we show it to them, and then subsequently they can
Fine,
manage on
fine.
their own.
Yeah. So when we have discussed all this, progesterone plays a very important role so far as maintenance of pregnancy is concerned. Any patient with less of progesterone or deficiency of progesterone can cause a miscarriage. And this has been proved in BMJ article that progesterone levels, which are lower than 6 to 10 nanograms per ml by 6 gestational week, it indicates that this pregnancy may not be very healthy and may not be very viable. And that's why this hormone has been, I'm just trying to go, these are some of the facts so far as miscarriage is concerned. Background risk of miscarriage is overall about 10 to 20%. Preclinical pregnancy loss is almost about 60%, which we don't realize it such. Recurrent miscarriage about 1 to 2%. Unexplained recurrent miscarriage is almost about 50%. And mind you, successful pregnancy without any intervention, that is spontaneous conception, is almost about 75%. And most of these miscarriages, they occur in the first trimester of pregnancy. Most of them, they occur that way. And that's why progesterone plays a very important role so far as maintenance of pregnancy is concerned. I just wanted to ask Dr. Nilakshi, is giving progesterone quite safe so far as mother and fetus is concerned? Dr. Nilakshi, please. Dr. Nilakshi?
Hello, can you hear me?
Yes, you can. We can hear you. Is giving progesterone, we bombard this patient with so much of progesterone left, right, and center. Is it quite safe for the mother as well as for the fetus? I just wanted you to say something on that.
So progesterone is very widely used for a pretty long time, but there are some studies which is to show that some progesterones have some deleterious effect on the fetus. Like before the allolesterone was used, but so far practically we are using it for a pretty long time. And for the fetus, I don't think there is any deleterious effect. But when we use in mother for a pretty long time, we have seen there are some liver enzyme sometimes it is raised.
Yeah.
And that is the only thing we have
Okay,
seen.
fine. So far as natural micronized progesterone is concerned and dihydrogesterone, they've not found any adverse maternal as well as fetal effects on a long-term basis. We go to the second case, Dr. Nilakshi. This is a fourth gravida, the 3 spontaneous abortion with 5 weeks of amenorrhea. Urine pregnancy test is positive. Serum beta HCG is around 5 to 6 weeks of pregnancy. She is married since last 2 years. And this is a spontaneous conception. She gives history of previous 3 spontaneous abortions. All were first trimester, 7, 8, and 10 weeks of gestation. Curettage done on all the 3 times. And last abortion was about 6 months ago. Blood investigations were all normal. Apla and thrombophilia profile is also normal. Karyotyping of couple was not done in spite of she having 3 spontaneous abortion. How will you go about managing this patient? Because this patient has come to you just with a spotting per vaginum, very little spotting, but she gives history of 3 first trimester spontaneous abortion. Dr. Nilakshi, please.
So it's a 5 weeks pregnancy, am I right?
Correct. Just about 5 weeks pregnancy. Yes. But
I will-
because she has had 3 abortions, little bleeding, and she is very apprehensive, so she has come to you.
So like this patient, I will definitely like to go for a serum beta HCG estimation. What is
Correct.
the level? Suppose it is it corresponds to the period of gestation, then we can assure the patient that yes, we may wait, and because you said she is APLA negative.
Yes, she is APLA negative. Thrombophilia profile is also normal. Only thing they have not done is a karyotyping of both husband and wife has not been done. Rest all investigations are normal. Everything is normal, ma'am.
So
And
definitely,
she was already on folic acid and low dose aspirin pre-conception, so she has continued with that.
so what I will like to, I would definitely like to go for progesterone. Definitely, I will
Correct.
prefer.
Yes. So progesterone will give it, that we have already discussed. What about aspirin, which she has been taking? She started spotting. Would you like to stop that aspirin, or would you still like her to continue with the aspirin? That is all what I wanted from your side.
Actually, we can continue aspirin,
Yes.
but the patients are very much apprehensive.
Correct. Yes, ma'am.
But there is no contraindication in continuing the aspirin.
Continuing. but
No,
then
this
patient-
question I had generally.
Yes, Raju. Yeah. Bolo, Raju.
I had discussed this with a hematologist, and they suggest that if the patient has come with bleeding, and if the patient is on either aspirin or on low dose heparin, it should be stopped for at least a week. You continue with all the other supportive measures, and once the bleeding has stopped and there is no bleeding for at least 3 days, then you can once again start with either of the.
Yes. That's
Brilliant.
what we've been doing it. Yes, we stop it for at least about 4 to 5 days. The
No, see-
bleeding stops and then you continue.
No, this you said just the spotting. There in
Yes,
this particular
spotting,
case,
but still, like, she is, because she has
can-
had 3 abortions, she is very hyper, ma'am.
Yeah.
Okay, Raju, a little bit I want you to talk on what about the immunological factors so far as recurrent abortion is concerned. This is one patient, she has all investigations normal, and in recurrent abortions, there are about 40 to 50% of these patients, there's absolutely no cause which is detected, and this is mainly because of a deficient immunosuppression. Raju, little bit light on that.
Yeah. Actually, a successful pregnancy is dependent on the immune reaction between the host, that is the mother, and the fetus, which is considered as a foreign body. And very often there is a certain amount of reaction which happens, and then there has to be a balance between the Th1 and the Th2 cytokines. The Th1 cytokines are the so-called bad cytokines. They are pro-inflammatory, and the Th2 cytokines are the good cytokines, which are the anti-inflammatory. So progesterone brings about a balance, a positive balance between them. That is one of the most important roles of progesterone, what we call immunomodulatory role, wherein it, there is the increase in the Th2 cytokines in favor of or against the Th1 cytokines, and that brings about a successful continuation of the pregnancy. So,
Yes. So what he says that, yes, somebody said something. Yeah.
No, yeah.
Progesterone induced binding.
Progesterone, yeah, about the progesterone. Yeah. So you can continue.
Yeah, so PIBF plays a very important role whereby which fetus is not taken as a foreign body and mother's body try to accept this. And they have carried out studies apart from serum progesterone. They've carried out studies on PIBF, and they have found that PIBF keeps on increasing as the gestational age advances, and it increases till almost about 37 weeks of gestation. So miscarriage is very high if PIBF levels are quite low. As said, this is just a study which has been going on, but for all practical purposes, we don't carry out. But in case you find patient with a recurrent abortions and all investigations are normal, you do have to keep it in mind that there is some immunological cause for which patient might need a specific treatment. That is all message that I wanted to give you. I would like to
One more point
again go
I
to
would like
Dr.
to just
Deepak.
add
Yes,
here,
follow.
that the APLA test which is done, ideally it should be done in the non-pregnant state. So had an abortion after a month or so, then the APLA test to see whether she had any antibodies. And also the history is important in all the 3 previous pregnancies. If there was a positive heartbeat seen on fetal heart seen on ultrasonography, maybe at 6 weeks, and then subsequently at 10 weeks, there is an absent.
She is at 3, so 6 and 8 they didn't find any heartbeats. 10 they found the heartbeats, but then heartbeat disappeared.
Correct. So, that
that's
is where
yeah.
there is likely that it could be an
APLA positive, but they found somehow APLA was negative. So that's the reason I'm saying if you find all investigations are normal, you have to keep immunological as one of the
Yes, absolutely,
this thing. Yes, immunodeficiency, and you need to treat the patient that way. I would like to go to Dr. Dipti for the third case. This is a 23 years old, second gravida with 1 spontaneous abortion. This was at 8 weeks. Right now, she's about 7 weeks amenorrhea. Cycles are regular. Routine sonography shows a simple intrauterine gestational sac of about 7 weeks. But when she went for a dating scan, cardiac activity was absent. So the sonologist labeled her as a missed abortion. She had little spotting, but nothing beyond that. What next will you do, Dr. Dipti?
So this seems to be a case of missed abortion, as the cardiac activity has not lookable on ultrasound.
When she went
And
for dating scan.
yes, so ultrasound is confirmatory in such cases because of absence of cardiac activity. And now the question arises: what next? Patient has many questions to ask: why it happened and what is going to be done to her.
That's right.
So that's right. So we answer question by question. We all know what are the causes and that can be told to the patient, but then what to offer her? You have put some question here, features of failed pregnancy, what else to look for, and fetal bradycardia. So I understand you are trying to ask about what are the features on ultrasound on basis of which missed abortion can be diagnosed.
Yes.
So there are a whole lot of.
I just wanted to, she has a very little spotting, and sometimes they are not ready to accept that it's an absent fetal heart. So would you tell them to wait for a week and then have it repeated, or have a second opinion on a sonography before you decide upon something for these patients?
Well, I think ultrasound is very, very confirmatory, but we can always honor a patient's wishes. And if she's not convinced, there is no harm in waiting for a week. But by and large, patients do understand the correctness of ultrasound and they are accepting. But in the exceptional cases, especially in precious pregnancy, 1 week waiting is not going to harm, but it is not required as such. Once we have found that it could be expensive.
And what reasons will you like to give it to us so far as missed abortion in the current pregnancy is concerned?
Yes. So we have to tell the most common cause is chromosomal anomaly. This baby was not formed properly, and this is God's way of doing away with something which is not perfectly formed, and this is the most common cause of early pregnancy losses. And of course, then there is a whole list of other causes, immune causes and others. But keeping in mind the very early pregnancy of 7 weeks, we would say that most likely it could be a chromosomal, something in the baby, a random occurrence.
Also in the
Yes, yes, it could be a random occurrence, and we can't really, fix one cause to it.
That's true. But then she needs to be thoroughly investigated because this
Yes,
is a repeat.
sure, this is repeat one. Yes, that's for sure.
I would like to ask Dr. Bishwajyoti.
I have one thing to tell, ma'am. Whenever we counsel the patient about the management, when they tell they want to wait for 1 more week or rest for some time, but we should tell them there may be sudden spontaneous bleeding in the midnight or any time.
Correct. So in that case, they should report immediately.
Immediately, and medical management has a less role. Usually, we will land in surgical evacuation. That should be ready.
Right. So I wanted to ask Dr. Bishwajyoti, but now that you only tell me, what type of management will you give it to her, medical or surgical, or which one would you prefer to give it to her in case she gives you, or in case you give her a choice? Dr. Pradeep, would you like to give her a medical management or surgical?
Yeah, of course, ma'am. After adequate counseling, after the explaining out the outcome, I think I prefer to give medical management always first. It works out very well. Most of the people will be completely evacuated. as per the standard regimen what we are giving, and they feel happy. I think rarely we land in surgical evacuation.
Yeah, but when you give medical management, would you like to counsel her and tell her that there could be a slight chance that there could be a possibility of retained products or something, because it's a missed abortion?
Yeah, of course. If it is, I mean, a small retained product, that also we could manage medically by doing a serial ultrasound with the additional misoprostol tablet with the antibiotic coverage. That's what we
Fine,
counsel
fine.
like that.
Yeah, Dr. Bishwajot, I want to ask you, what about her counseling and what about contraceptive advice?
See, first
this
of all,
patient.
when this lady comes to me
Yes.
with a history of query miscarriage, mainly what happens is that the ultrasoundologist will write down, repeat the scan after 10 days.
Yes, that's what they always write.
They
down,
always
correct.
do. So you have to discuss this with the patient, and if the patient if the patient is convinced that this pregnancy is no longer viable, or also we can do a beta HCG, serial beta HCG, and so that it's going down, then we can actually advise her and go for a medical management, as Dr. Ganiga said.
Yes.
Yeah, you go for a medical management, offer a medical management at the beginning. Now, regarding counseling advice and the interpregnancy interval, you see there are lots of studies which show that there is no evidence in saying that you should wait for 3 or 4 months before you try for pregnancy again. But at the same time, because of the hardship that the mother went through,
A little bit of a psychological impact.
A little bit of a psychological impact.
Yes.
It's always
We always
better
tell them to wait for at least 3 months.
You just tell them for emotional reasons, just to wait
That's
for
right.
3 months and then try for pregnancy.
Fine,
And
fine.
any contraceptive advice, I would ask them to use a barrier contraception at that point of
Fine.
time.
That's right.
And of course, even if we go for a medical management, and that is why we always do a blood grouping and RH typing, because if she is a negative
Yes,
blood
so
group,
if she's negative, what dosage and when would you like to give her?
see, I would
Yes.
give her 100 microgram of this
Anti-D, yeah, but
anti-D,
sometimes 100 is
but
not available, doctor.
not available. In that
Yes.
case, I'll give her 300.
That's
So
right.
if
If it
it's
is not
more, it
available,
doesn't
it's
do
better
any
to
harm.
give 300. Yes.
Yeah.
Yeah. Dr. Raju, I wanted to ask you. Now, this is a patient of a missed abortion. Now, a couple is asking whether would you like to send these products for any testing or something.
That is why I was just going to
For
say
this
that.
patient, I'm asking. This is a second time she has had a missed abortion.
Correct. So I was just going to suggest that in this patient, since it is a second, and again, since the fetal heart is absent at the very early stage.
First dating scan only.
Yes.
Declare for
Yeah.
that.
So that
Yes.
as you said, this could be a case of a genetic, a chromosomal anomaly or aneuploidy.
Yes.
It is better that we suggest to them the karyotyping of the products of conception. Subsequently, yes, even the parental karyotyping needs to be done, but at least right now, you can counsel them about the need or the option available of doing a karyotype or probably a microarray, I would say, of the products of conception.
Microarray will be helpful,
then,
but Raju, that amounts to them spending money for this, as well as in case later on they need parental karyotyping, they would be spending money for that too.
Yeah, but then the microarray will, it's an important advantage because first of all, whether there was an aneuploidy or any other genetic problem. And if there is one, then you always have the option of, checking it out in the subsequent pregnancy.
So
Yes.
nowadays, karyotyping is very important. Whether it costs a little bit extra does not matter.
Yeah.
It's always advisable to tell the patient.
And today it
that
is
we
not
will
just
send the products.
karyotyping. I would say it is microarray.
Microarray is of the importance.
Exactly.
Yes.
I agree with Dr. Nagarkar. So it should be a micro.
Yes. Okay. So we go to the next case. So this is a fourth case. We'll start off with Dr. Krishna Kumari. This is a 32 years old patient. She gives history of 2 spontaneous abortion at between around 6 to 7 weeks. When we did our anti-cardiolipin antibodies, IgG was positive, so as IgM. What are the diagnostic criteria you would like to label this patient as an APLA?
So when we are looking at APLA, so always it is better to do it in the interpregnancy interval.
Correct. So
which
this
is
was
not,
done in the interpregnancy. I just wanted to have little discussion on APLA positive. That's all, nothing else.
Okay. So what we are doing is the lupus anticoagulant and the ACA, both the IgG and the IgM. And of course, sometimes we also are sending for the beta-2 glycoprotein one if the patient is affordable. Then either we go with the lab diagnosis, which are done 2 times with a gap of.
Yeah. So I just wanted to ask you, if you get one the first time and you get positive, do you still ask them to do it after 6 to
Yes.
8 weeks, or you
Yes.
just rely on one report and only you start treating the patient?
No, it has to be repeated before we and confirmed, unless we have a clinical criteria also. So we also do have a clinical criteria for saying it is APLA positive. If the clinical criteria is strong enough, then probably we may avoid the second
second time. But if at all clinical criteria is not there, it's always better to have it done 2 times, correct?
Yes.
Now this patient has conceived. What type of a treatment would you like to give for patient who is APLA positive? What is your
Heparin-
treatment of choice? Yes.
Heparin and aspirin, a combination of heparin and
So aspirin, do you start in a preconception stage along with folic acid, and heparin once she conceives, or how do you go about doing it?
Yes, we start aspirin in the before the patient. In the preconception when she plans a pregnancy, and heparin once the scan confirmation is done.
Is it only scan confirmation of intrauterine pregnancy, or is it scan confirmation of fetal viability?
Fetal viability. It is a fetal viability.
But there are at times we have waited for fetal viability and you don't get fetal viability. Then how do you go about? That has also happened with me.
Oh, so I think that is a tough thing to.
In bad obstetric history cases, especially like the first case where there were 3 abortions, I prefer to start as soon as I see the patient, even if she is 3 days. Yes, because like you rightly said, that initial blood flow is also important. It matters. And as you want to wait, if you wait till the heartbeats come, it may never happen. And because I don't know whether it is a psychological thing or what, but I have seen actually a bradycardia turn into a normal heart rate after starting aspirin.
So, yeah, but I'm very uncomfortable. The moment I fight pregnancy, I start off with heparin because I'm very skeptical about, starting heparin late.
There is, we used to previously, there was a thought that we'll start aspirin preconceptionally, and as soon as the fetal heart appears, we start low molecular heparin. But now I would rather tend to agree with Dr. Nagarkatti, and I actually, if I get a APLA positive who had lost 3 previous pregnancies, of course the aspirin will be started at a preconception period, and I tend to start my low molecular weight heparin earlier than even if she has gone for the first scan. So once
doctor,
she
comes, I agree with her. I agree with you.
Once she has a pregnancy test positive, I start her, hoping that she will not bleed.
Correct. What about anybody has used unfractionated heparin? All of us, we use low molecular weight heparin in private practice, but in public hospital, has somebody used unfractionated heparin? If so, what are the precautions that you need to take when somebody is on unfractionated heparin?
Nowadays nobody is using this, even in public hospitals, but we have used it when this was not in public hospitals, where enoxaparin was not so freely available. And even when patient is not affording, there is a cost difference too. So unfractionated heparin was used, but then the dosage is more frequent, and patient used to get those blue spots all over and definitely more uncomfortable.
That's right.
So all those things were there.
With low molecular weight heparin, you can use 40 milligrams or 60 milligrams depending upon the weight of the patient. You need to teach the patient how to use this subcutaneous injection because she needs to take it daily. Till how long will you continue? 34 weeks or 36 weeks? Or till she delivers? Somebody?
Yes, I will continue it until...
Yes, Dr. Krishna Kumari, tell me. You will
Yeah.
continue till?
Yeah, I will continue it unless she sets in. I mean, usually we prefer to wait till she's at least term pregnancy. And then after that, if she planning for an elective section, maybe just the day before, I would like to stop it. Otherwise,
Yes.
there is no need for us to stop the treatment.
Correct. So, correct. So it is better to continue till you try and deliver her, because unless you stop it and if something goes wrong, everybody is very skeptical. So we don't stop in between.
But in some cases, with aplar and risk of thrombosis, one may even have to give it in the postpartum period.
Okay.
That you have to, because aplar is not one, it may not be.
Dr. Goswami
Yes,
is
it is
actually
not
quite
related
right.
only to pregnancy. I understand
yeah,
that. But
because
postpartum, at least I have not continued.
even in the postpartum period, these chances are has a chance of developing
Develop a
DVT.
venous thrombosis.
So,
Yes,
so
correct.
we
Yes.
do actually continue this low molecular heparin up to 6 weeks after in the postpartum.
After postpartum.
Absolutely, absolutely.
If the patient is not affording, then what I do is once she is crossed 20 weeks, I do the aplar test. Normally we do the beta 2 glycoproteins, the anti-cardiolipin antibodies, and the lupus anticoagulant.
Correct.
And if on 2 consecutive reports at 6 weeks apart, if they are both negative, then with due counseling, we stop the injections for both reasons. Sometimes it is cost also, and sometimes the injections are painful and the patient is just not able to take them. In that case, we do the tests, and if the tests are, in 2 different reports, if they are all negative, then we can probably go ahead and stop the injections.
But then, Raju, you continue with aspirin, correct? Low dose aspirin.
Yes,
is
yes,
still
aspirin
on,
we
right?
continue. Aspirin is
Aspirin you will
continued because.
give it to.
And Dr. Dalvi, there is a little bit controversy regarding aspirin, whether we should continue it till delivery or we should stop it
No,
at
not till
36
delivery.
weeks.
We
We stop
continue
it
till
till
34
36,
weeks.
37 weeks.
Yeah.
36
we
weeks, I
continue
think
till
is,
about 34, 35 weeks, and then we stop it. We don't continue beyond that.
yeah.
Okay, this is the last case. Of course, Dr. Bhaskar has already spoken about ectopic, but little bit I thought we'll just discuss it. 35 years old, primary, married since last 4 years. She gives history of 5 weeks of amenorrhea. She gives a past history of diagnostic hysterolaparoscopy done about a year ago. She conceived with ovulation induction and IUI in the first cycle itself. Blood investigations are normal. Urine pregnancy test, home urine pregnancy test was positive. She comes to you with a pain in the lower abdomen on and off in last 4 days. And then she started bleeding per vaginum just last about 2 hours. Anyone, how will you go about treating this patient? She has come to you with these complaints. On examination, all parameters are normal. Repeat urine pregnancy test was positive. Lower abdominal tenderness on deep palpation. And per vaginum, cervix is normal. Uterus a little bulky, but there is some little tenderness. So anybody with clinical diagnosis, and how will you go about this patient?
Most probably that will be a case of ectopic pregnancy, but before.
Yes, it looks like, yeah, from the clinical symptoms, yes. So how will
Yes.
you go about treating this patient?
I will go for an serum beta HCG and transvaginal sonography. So from there we will come to know whether it is ectopic or not. If it is ectopic, that's the beta HCG level and size of the mass that will decide the mode of treatment, whether we should go for surgical treatment or a conservative method of treatment.
Yes, madam. Now this is a report. Sonography, urgent sonography shows a single extrauterine gestational sac in left adnexa, very closely abutting the left ovary. Sac is about 5.1 weeks and tiny yolk sac, but no fetal pole is seen. Cervix is 3.4 centimeters. Internal os is closed. How will you go about treating this patient? She's admitted
the beta HCG level can help us decide. Patient is vitally stable. There is no free fluid. The mass of sac is very small. It's an unruptured topic. And beta HCG will help us. Beta HCG level can help us triage whether she goes into what type of. So what I will do is, if it is less than 1000 beta HCG, I can offer her expectant management, meaning thereby that I keep a close watch on her, but I do not give any medical or surgical treatment. And we repeat beta HCG and see if it is declining, then expectant can be successful. But if the value is more than 1000, but it is less than 5,000, then she could be a candidate for the medical treatment, methotrexate, 50 milligram per meter square. In
Yes,
fact, last
madam,
year
when you're
itself,
giving, one second, when you're giving
yeah.
medical treatment, patient will still remain with you in the hospital, correct? You
Yes,
don't give it on an OPD basis, right?
and it is important. Yeah, and it is very important to get a complete blood count, KFT and LFT count before you administer methotrexate to the patient. And we have to be mindful. In occasional patient, there can be severe reaction to methotrexate also. So at least in my setup, in my unit, in my hospital, we are admitting and are giving it under supervision.
Correct. So
This is what my protocol is.
all patients, you give medical treatment, it is always better to admit this patients so that you can, in case patient has not responded, Dr. Pradeep, you've given methotrexate, but beta HCG is still rising. Then what will you do? Dr. Pradeep, after 48 hours, beta HCG is still rising. You've given one shot of methotrexate. What will you do, Dr. Pradeep?
Yeah, I think, yes, depending on the increase in the beta HCG value.
Your voice is not very...
Voice is not clear.
Yeah.
Yeah, I think this is a role for second dose. What we do in the day-to-day practice after counseling the patient. But most of the patient will agree for the second dose. If they are not willing to ask for the surgical, then we have to go for a surgical management, depending on the
Correct.
patient.
So in case patient doesn't respond to the first dose, you can ask for a second dose, repeat dose, but need to counsel the patient that this is what we are doing it. And at the end of all that also, if patient doesn't respond, then of course a surgical therapy. Dr. Bhaskar has already told us about salpingectomy versus salpingostomy. So I'm not going to go into the details. Once you have treated this patient, how will you follow up? The Nilakshi?
So when we for the medical management, we have to go for the serial beta HCG estimation, and we have to go for serial sonography to see the size of the mass and your free fluid. But the size of the mass, it will take some time for resolution, but it will the beta HCG level, which will tell us whether this medical management is working or not. And suppose for the surgical management, I think we better go for salpingectomy in this group of patients.
Yeah, that we leave it to the each of the consultants, and of course how they counsel with the patient. If it's a primary, then sometimes you try and do salpingectomy, and the patient and the relatives don't give you consent for salpingectomy because they feel removal of one tube is going to create a lots of problem. So sometimes they don't give, and then you have no other choice but to resort to salpingostomy. Dr. Raju, you want to say something on that, and then we wind up for today's panel discussion.
I think Dr. Raju has left.
Dr. Raju has left. Dr. Bishwajot, you can say, and then we
I
wind up for
didn't follow the case. Just
Dr. Raju is there, very much there.
Oh, okay,
fine, Raju.
Yeah. Sorry, what was the question?
Both of y'all can say one after the other.
No, fine. Let Dr. Raju say.
What was the question? Sorry,
I just wanted to know surgical management of an unruptured ectopic. Bhaskar has already said about salpingostomy versus salpingectomy. But if it's a primary patient and she has had first ectopic, then sometimes they don't give you consent for a salpingectomy. Then how would you counsel the patient and how would you go about it? You must have faced this in your practice.
Yes. I mean, we know that salpingectomy is a safe approach because the chances of subsequent bleeding, subsequent continuing HCG activity, etc., are going to be there, and also the very high risk of a recurrent or repeat ectopic in that same tube is more than 50% in cases of salpingectomy. So the salpingectomy would be a safer approach. But yes, if she is a primary and had a previous
they don't
ectopic,
give you consent.
Yeah,
patient
so in that
and relatives don't give you
can
consent.
counsel them, and then you can go ahead with the salpingotomy with counseling, explaining all the risks, and you need to be patient with the salpingotomy to just confirm that the bleeding has properly stopped, because
Correct. So you need to
oozing
it
keeps
well.
continuing for some time, and then you have to be very sure that the bleeding has actually stopped, because we don't want to go in again if the hemoperitoneum continues.
Yeah, but Dr. Bhaskar already showed a study in which he found that there is no difference between salpingectomy and salpingostomy with a next intrauterine pregnancy. Incidence is more or less the same. So you can decide whatever is the
No,
best.
but if you have done salpingectomy, then at least in that tube there is no question of an ectopic
Having
again.
a repeat ectopic.
If you have done a salpingostomy or a salpingotomy, then in
There are
that
chances that she could
there is
have
a
a
very
repeat
high
ectopic
chance
in
of
the
a
same
repeat.
in
If
the
the
same
contralateral tube is normal, then that's fine. She can always conceive normally through that particular tube.
So thank you so much, all the panelists. And I would like to say the last thing, science may set limits to the knowledge, but it should not set limits to our imagination. And at an outset, I would like to thank again Dr. Bhaskar Pal and his team for giving us an opportunity to have this. I would have asked for one comment from each panelist, but I think we have already finished with the time.
The only comment we would like to make is all the best to Dr. Bhaskar.
Yes, that
We
I've
want to
already
see
wished
you.
him. I've already wished him.
Thank you.
Yes.
I think while we said that, I did say that salpingectomy is the better option compared to salpingotomy. But if you're doing salpingotomy, I think what important take-home points is do not attempt a
Yes, sir.
salpingotomy if this is a live ectopic. Number 2, please inject vasopressin to decrease the bleeding. Number 3 is that do not injudiciously use cauterization. Try and minimize your use of energy. Use a lot of irrigation. With irrigation, a lot of bleeding would settle. And use a minimal bipolar wherever it is needed, because a badly done salpingotomy is much worse. Yes, sometimes it is
Absolutely.
difficult because patients start thinking that if the both tubes are there, there's a better chance that they'll get pregnant in the future. But counseling is important. If we counsel them properly, most patients finally agree that having one healthy tube would be better for them.
Yes.
Thank you, Dr.
Thank you
Dalvi.
so much. We finished
Da-
on time. Yes.
Thank you, Dr. Dalvi. It was an excellent
I think,
moderation.
yeah, it's been an excellent moderation. It's been an excellent program, and I
Thank
think
you.
it's brilliant that we've finished on time. It's
Yes.
it's a very crisp program, and we will again meet on the next Wednesday on 25th of September, and that's also Wisdom O. And we have one talk on dengue in pregnancy at the present moment. Of course, dengue is decreasing, but dengue has been a big problem in the last couple of months. And one talk on malaria in pregnancy and a panel discussion on anemia in pregnancy.
Thank
Thank
you
you.
so much.
Ella and
Thank
Shoma.
you all the panelists. Bye.
Thank
Good
you.
night.
Thank you. Bye-bye. Good
Bye.
night
Thank
and
you,
bye-bye.
Bhaskar.
Good
Thank
night.
you, everyone. Good to see everyone.
Yeah,
Ella,
nice
Shoma.
to see you all. Thank you.
Okay. Shoma, you can say.
Thank you, everyone. So it's time we wrap up. Thank you for all your time, and in spite of all your busy schedule, and happy Durga Puja and happy Navratri to all of you. Thank you.
Thank you.
Thank you.
Can we leave, sir?
Yeah, you can leave.